Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is melanoma. So what is melanoma? This is a tumour arising from melanocytes and is a leading cause of death from skin cancer. The incidence of melanoma has tripled since the 1980s, and there is a direct correlation with Caucasians in high UV intensity countries, such as Australia and New Zealand. There are various risk factors for developing melanoma, including skin type 1, a history of multiple episodes of sunburn, family history of melanoma, previous history of melanoma, multiple melanocytic nevi, and atypical nevi. Diagnosis of melanoma is partially done by using the ABCD assessment tool, and this is really crucial when you are suspecting melanoma in someone when you see them for the first time and you're assessing a lesion, and it's also a good way of assessing lesions over time as well. So the ABCD score stands for A for asymmetry, B for border irregularity, C for color variegation, and D for diameter greater than 6 millimeters. There are 6 types of melanoma. So firstly, there is superficial spreading, and this presents as pigmented macules. And as we've just found out, these macules can be assessed using the ABCD score. The next type is lentigo maligna, and this is confined to the dermal epidermal junction. So in effect, the melanoma is still in situ. Classically, this appears on the cheek of an elderly patient with sun-damaged skin. This is also characterized by flat, irregular-shaped pigmented macules. The next type of melanoma is nodular melanoma, and these lesions are usually more advanced with poorer prognosis. These can also ulcerate, which correlates with poorer prognosis. The fourth type is acral lentiginous melanoma, and these arise on the palms or soles. They're quite rare in Caucasians, and they are the most common subtypes in Japanese or Chinese individuals. The fifth type is amelanotic melanoma, and this presents as skin-coloured maculae, papules, or nodules. These can have a weeping or a bleeding appearance. And the final type are subungual melanomas, which present as pigmented streaks in a finger or toenail. It's important to examine closely for Hutchinson's sign, which is the pigmentation of the proximal nail fold. This is an example of how a melanoma would appear. So as you can see, this gives a classic example of how you can use the ABCD score to assess for all the factors that we talked about earlier. In terms of investigations, history and clinical examination is key, and it's really important to examine the whole skin, not just the area where the lesion is, in case there are any occult lesions. And it's really also important to check the lymph nodes for spread. Dermoscopy is used to further examine the lesions, and lesions are then usually excised and sent for histopathology. Sentinel lymph node biopsy may also be useful. Prognosis depends on the depth of invasion measured by Breslow thickness. This is the vertical tumour depth in millimeters from the granular cell layer of the epidermis. Prognosis is close to 100% survival if the melanoma is fully excised at an early stage. Treatment is usually with surgical excision, leaving a 2 millimeter margin of clearance. Wider excisions depend on the Breslow thickness. Radiotherapy and chemotherapy are used, and immunotherapy may be required for more advanced disease. Melanoma can be associated with various other conditions, and these include the use of immunosuppression, including following organ transplants, HIV, and rare inherited conditions such as xeroderma pigmentosum. Now let's try a question. So a 40-year-old Caucasian lady presents with a 4-week history of pigmented 2-centimeter lesion on her cheek with asymmetrical border. Which of the following factors is not relevant in the assessment for a malignant melanoma? So our options here are color variegation, border irregularity, diameter greater than 6 millimeters, asymmetrical, or discharge from lesion. So this question is asking you to remember the ABCD assessment of a melanoma, and you'll remember that all of these are present in that score, aside from looking for discharge from a lesion. However, that is something you would want to make note of and investigate further separately, but it isn't part of the ABCD score. Thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in future. See you in our next episode.